Well, good afternoon, everyone, and thank you for joining us for our final MS Academy webinar for 2022. The topic for today's discussion is MRI and monitoring response to MS disease-modifying therapies. I'm joined this afternoon by Dr. Audrey Sinclair from St George's in London and Liz Woodhead from Sheffield. We're going to be discussing some of these issues. Okay, so just to kick off, I just wanted to set the scene and put to you that MRI, I think, is our most important tool that we have for monitoring the evolution of multiple sclerosis. This is a patient from one of our CIS studies at Queen Square, and you can see the patient's been followed from disease onset with MS, where even at the time of their first clinical symptoms, there was already sign of established pathology in the brain with multiple white matter lesions that were asymptomatic. And for a young person, maybe already even a degree of loss of brain volume with some enlargement of the lateral ventricles. And this person was untreated. Of course, this was from an era where treatment wasn't widely available. And you can see over time the evolution of their disease with an increasing number of T2 lesions developing over 15 years, increasing brain atrophy, and that's paralleled by worsening and progression of their MS from CIS to secondary progressive MS over a 15-year period. And really, MRI has three main roles or tools. It's helpful in establishing a diagnosis of MS and differential diagnosis. It's useful for the selection and monitoring of response to disease-modifying therapies, and that's going to be our main focus for discussions today. And it can also be very, very helpful in monitoring for the complications of the treatment that we use, and principally that's PML. Now, just to set the scene, I wanted to share with you a case from my own practice. This is a 27-year-old woman with relapsing remitting MS. She was diagnosed in early 2020. She had brain and spinal cord lesions, quite typical of MS, and positive oligoclonal bands. And she went on to treatment with dimethyl fumarate in mid-2020. And she's been quite well since then, with an MRI scan in 2021 showing stable disease. But then she had a further follow-up MRI in summer 2022, and these were the findings. So she had two new lesions on the scan. You can see her scan from summer 2021 on the left and summer 2022 on the right, with these new lesions. And even this lesion here shows a lot of swelling around that looks like a fried egg. It wasn't producing any symptoms. She was perfectly well. And really, this is what we're looking for, change in the MRI to help us decide whether the treatments we offer patients are working or not. Because we know from large cohort studies, observational studies, that people who have ongoing MRI activity and relapses while taking DMTs have worse outcomes. And the blue line here is people who were relapse-free but had relatively small changes on their MRI, one or two new lesions, and they were doing worse after 3 years than people whose MRI scans were stable. And we know also that escalation of treatment on the basis of MRI activity rather than waiting for relapses is associated with more favourable outcomes for patients. So this is data from the casting study, looking at people who are not doing well on a first-line treatment and looking at a switch to ocrelizumab. And this was first presented at the EAN a couple of years ago and then published earlier this year. And you can see that people who are escalating to ocrelizumab on the basis of MRI activity alone were doing better than people who waited for a relapse to escalate their treatment. And so really MRI is the tool that we're using to judge whether patients are responding well to treatment. Now I'm going to hand over to Dr. Audrey Sinclair at this stage. Audrey's a consultant neuroradiologist. She's going to tell us about what the guidelines say about what we should be doing. Whether we actually do it is another story, but Audrey, over to you.
Thank you, Wallace. So yeah, the guidelines have been in development for quite a while, and they've been really needed because I think most people who take part in an MS-MGT or work in MS will know that there's such a huge variation in how patients are scanned and how difficult it is when we're coming to compare scans from one hospital to another, how management decisions can be delayed. because we can't make a decision because of technical differences between scans, and we can't tell if there really is a new lesion or not. So the guidelines being developed by the British Society of Neuroradiologists in conjunction with the Association of British Neurologists are quite simple with and specify timing and how to do scanning, including what planes and what sequences to do. So the first part of the guidelines addresses timing, when to do an MRI scan. So following diagnosis, we're going down this middle trunk. Sorry, can't use my pointer. Yeah, down that middle trunk where you see DMT started, and then we recommend doing a rebaseline scan at 6 months. And the reason for doing, for simplifying it and saying do the rebaseline scan at 6 months is because at 6 months most treatments will be at full efficacy, and therefore this increases the confidence that you have that any new lesions developing after this point would represent breakthrough disease on treatment. If you do it a little bit earlier than that, and it gets too complicated if you try and tailor it to the drug. So we use a blanket 6 months, rebaseline everybody at 6 months. And I think it's important at this stage to do both the brain and cord to make sure that you've monitored the whole CNS at this point. So you've got a post-commencement of treatment baseline of the whole CNS. Following this, we recommend doing in an ideal world, do brain and the whole cord annually, so at 12 months, 24 months, and 36 months, etc. In patients without cord disease or with no cord lesions after a year or two, you can consider reducing the frequency. However, if there are capacity issues, because obviously we have to be pragmatic and do what we can based on the resources we have. But this is in an ideal world, we'd like to image brain and cord, and that's what we do at St George's for most patients have brain and cord. Anybody without cord disease and is stable, we might do the cord every couple of years rather than every year. Other times to think about rebaselining, it's important to try and get a rebaseline MRI postpartum, because this is an unstable time where disease can become unstable. So it's very useful if you can get an early postpartum MRI, but this isn't always practical. And also on switching treatment, it's good to rebaseline as well, for exactly the same reasons as you rebaseline in the first place. And all of it, these recommendations are in keeping with the consensus paper that came out last year, the consensus between Magnim's, the consortium of MS centres, and the North American Imaging and MS groups. So in progressive MS, MRI is predominantly important in demonstrating disease activity in order to demonstrate if a patient is eligible for treatment. And this is often quite challenging because a lot of progressive patients, particularly the secondary progressive patients, don't have recent imaging. NICE doesn't specify how recent the imaging has to be, but in the Oratorio trial, the inclusion criteria was 3 years, an MRI within the last 3 years, and on Blue Tech for ocrelizumab, that states within the last 3 years as well, but it's not specified for siponimod. When there is no recent imaging, it can also be quite useful to demonstrate a gadolinium enhancing lesion. So you can consider using gadolinium in this group of patients as a one-off on the first scan if they've not had one for ages. So what sequences do we do? The bread and butter is the 3D flare. Yeah, Wallace, if you can play that, if you click on that, that should show you the difference between a 2D flare sequence and a 3D flare sequence in the same patient. And you should hopefully be able to see the superior quality, the resolution, and the lesion conspicuity on a 3D flare sequence compared to a 2D flare sequence. So a good quality 3D flare sequence mitigates the need for giving gadolinium in follow-up, and for doing additional T2 sequences as well. So if you get a really good quality 3D flare sequence, that's virtually all you need for follow-up to find a new lesion. Diffusion weighted imaging, DWI, can be helpful. It's not very helpful in MS or aging lesions. It's not very reliable in aging MS lesions, but it can be helpful in PML monitoring. So 3D flare and DWI are useful in trying to identify progressive multifocal leukoencephalopathy. And then the volume T1 is really useful at looking at volume changes over time. So not something to do every single year, but perhaps every 2 or 3 years to try and look at volume changes. And this may become more important in the future. We're onto the cord sequences. What sequences do we need to do in the cord? Now, the most important part of the cord imaging is to make sure you get an axial sequence, is to make sure you do both the sagittal and axial. So a lot of centers just do the sagittal sequence, and this is often a 3mm or 5mm. Sometimes there's a gap between slices and you don't see the lesion. Whereas if you do axial sequences, you're getting the whole cross section of the cord, and it's much easier to identify lesions. So there was a paper that showed, if you the references at the bottom, if you look at 2 planes of the cord imaging, you pick up a lot more lesions just compared with just a sagittal. And certainly in my own practice, I find this really, really important to look at the axial T2 image. The STIR is a fat suppressed sequence, and that makes lesions a little bit more obvious and easy to spot. The lesion that I'm showing on the screen is in the middle of the screen, about T3, T4 level on the sagittal. Really not very obvious. A little bit more obvious on the STIR, but very obvious on the axial sequence. So if you're going to do cord imaging, make sure to do the axial images, because that does solve an awful lot of problems. So what do we look for when we're doing MRIs? Predominantly, we're identifying new lesions and enlarging lesions. So enlarging lesions, either lesions that are forming on the edge of a previous lesion, or chronic inflammatory lesions that are slowly expanding. So that's the mainstay, is identifying new lesions. But we're also looking for other markers of disease activity, which can be much harder to see on standard 1.5 Tesla MRI. So the electromeningeal enhancement and these paramagnetic rims from these chronic smoldering lesions, you really need to use a higher Tesla 3T at least scanner to see these lesions. So not done in most MS centers, and that's an extra. Those are extra little findings, but not the bread and butter stuff. The other important part of monitoring patients on DMTs is to look for complications, treatment complications, and comorbidities. So patients can develop other diseases, TIAs, chronic small vessel disease, and so there's an element of surveillance as well, looking for not just new lesions. An important part of monitoring is the MDT, because having a weekly MDT or a regular MDT where you've got access to neuroradiology input and a clinical team having a discussion with the neuroradiologist gives you a much better quality of decision making. Just a radiologist sitting in a room reporting in isolation, not hearing what the clinical state of the patient is, gives you a poorer quality report than if you assess the imaging together. So that's an important of. So what next? What does the future hold in MRI monitoring? I think there's an awful lot written, and Magnum's has made the most of lockdown and really been publishing prolifically over the last couple of years, talking about atrophy, talking about harmonizing MRI data. And I think all of this is really important. I think that we're going to be doing a lot more whole brain and cord volumes. This has been talked about for years. We know that this is an important part of MS disease, that patients lose brain volume, certainly from quite early on, even before they become clinically, obviously clinically active. So we know that even in radiologically isolated syndrome and clinically isolated syndrome, patients lose brain volume. So I think we'll be doing a lot more brain volume monitoring, both for prognostic purposes as well as for monitoring response to treatment. So there have been several studies showing that that you can get a reduction in brain volume reduction as a response to treatment. So if you treat the disease effectively, you slow down the volume loss in patients. I think it's going to be really important that we harmonize, we standardize the way we image patients so that patients can easily move from center to center, decisions can be made much more quickly, and you can identify treatment failure much earlier and switch patients earlier, because there's an awful lot of data to show that patients do much better if they get effectively treated early on. We should all be using isometric 3D sequences already, and these will come into their own when we're using AI and deep learning, because these volumes of data can then be manipulated much more easily. So it gives you much better resolution, but also allows you to try and work out volumes, particularly when you're using these automated and semi-automated. Here are a couple of examples of a couple of companies that are already doing research work and trialing the use of AI and automated segmentation in clinical practice. So I think that's where we're going to be heading and doing a lot more of this. And I think that's the end of my slides.
Fantastic. Thank you for that overview, Audrey. So we're going to move from some of the kind of more technical aspects of what we do, understanding why we do it and monitoring patients with MRI, to dealing with the queries that we face and discussing MRI with our patients. So Liz, over to you to talk about some of these questions that we face every day.
Thank you. And there are questions that we get time and time again, directed either to the consultants or to us MS nurses, and they can be really difficult to work out because everyone's so individual, and MRI is quite a complicated area at times. So I quite often try to work out logically in my head why a decision may have been made either before I talk to a patient or kind of going through it with them, obviously, to make sure that they're getting the right information. But the first question is, why did they not give me the contrast dye? And the most obvious, if someone's pregnant, of course, or potentially breastfeeding, although I know if a lady is breastfeeding and they need a postpartum re-baseline scan, they can express and kind of get rid of that milk. But what I thought mostly was the fact that if it's a routine scan to see whether a disease-modifying therapy is working, they haven't necessarily got clinical signs or symptoms, so activity may not be expected. Although, of course, you can have sort of asymptomatic lesions or active lesions without knowing about it. And also, if there's a monitoring scan for PML, then there's no, it's not necessary to always do contrast dye or gadolinium. When I was looking into this question, I was looking at the concern about gadolinium accumulation, and just wondered, Audrey, really whether it is a concern. I couldn't see that there was any evidence of harm to patients, but just wondered your opinion.
Yeah, that's quite right, Liz. So there's been evidence to show that gadolinium accumulates in the brain, in particular areas of the brain, in the basal ganglia and the dentate nuclei. So there's good evidence that that the accumulation occurs, so you get this deposition, but there's no evidence of harm. And what's been shown is that the deposition occurs less with macrocyclic, sort of a particular type of gadolinium, which has a sort of circular formation rather than a linear gadolinium. So the European Medicines Agencies and the FDA have banned the use of linear gadolinium, which crosses the blood-brain barrier and deposits in the brain more. And so now we use safer macrocyclic gadolinium. There is no evidence of harm, but it's instinctive that we don't want to wait till we get evidence of harm if it does indeed, if it does indeed come. So we use gadolinium when we need to use gadolinium for a diagnosis or to show something. But in monitoring of MS, by and large, we don't need it. In certain, Wallace, I think I've got a slide on this next. Could you go forwards?
Yeah, so I think this is one of your examples, Audrey.
Yeah, so it's gadolinium is really useful in certain instances. We don't need it routinely because to spot a new lesion with a 3D flare, we're just counting the dots. But in certain patients, for example, this patient where they've got very confluent lesions, they're nearly all joined up. So to be able to spot a new lesion in amongst this is quite tricky. And in patients like this, I think it would be judicious to give gadolinium. And we don't ever do a double dose of gadolinium. We just give a single dose of gadolinium. And we allow a 10-minute gap as well, so that you get good concentration, so that you've made the most of that gadolinium dose.
For radiologists, Audrey, that's quite a lot of extra time, isn't it? That's a person with an acute stroke you can't get through in that 10 minutes. Is that right?
So yes, good point. Except that usually you're doing a couple of sequences. The sequences usually take about 6 minutes, 5-6 minutes a sequence. So if you give the gadolinium right at the beginning, so unless you're needing a pre-gadolinium T1, you could give the gadolinium right at the beginning and do all of your sequences post-gadolinium. And in fact, a post-gadolinium flare makes lesions more conspicuous anyway. So if you're giving gadolinium, it's a really good thing to give the gadolinium before you give the flare, before you do the flare. And they do this in quite a lot of oncology patients as well. This is where the use of a gadolinium enhanced flare first came to my attention, was in the oncology centres, and that really helps with conspicuity. So we waste very little time.
And I guess a lot of this depends on context, doesn't it? So in the current era where we're increasingly using high efficacy therapies for not just people with aggressive MS, but we're offering them early, including first line, the chances of finding a new GAD enhancing lesion, say someone's been on a high efficacy therapy for 2 years, the chances of a new GAD enhancing lesion are really low, right? In the next session, we're going to talk about Kesimpta, which might reduce the risk of a GAD enhancing lesion by 98% versus an active comparator. And so we'd have to scan hundreds of patients to find a new lesion if we just do this for everyone. Would that be right, Audrey?
Yeah. So the yield will be pretty low. So the expense, the time, all of that adds up.
Do patients like getting gadolinium, Liz? What do you think? Do you think they complain about the IV line being inserted? Do they want it, or generally they don't like their
I think most do want it, just so it seems like it's completely thorough and they know exactly what's going on then. And yeah, it's probably why they ask the question, really. There will be the odd few that don't like the whole process, but the cannula in and everything. But yeah, I think generally they do.
I think that most patients who haven't got very confluent lesions, they can be reassured that with good quality imaging, we really don't need it at all. And I wouldn't like to have repeated doses of gadolinium, just because there's still an unknown factor.
Yeah, it makes perfect sense. And having something that's not necessary all the time. So the next question is, why am I not having a spinal cord MRI? And I suppose this was quite a difficult one for me. And I think that generally it goes on the clinical signs and symptoms. Again, if it was a monitoring MRI for something like PML, then it wouldn't be needed. It was just needed a brain scan. And correct me if I'm wrong, but I believe that if you have symptoms that it's maybe more obvious if it's a spinal cord lesion, or maybe the symptoms are a bit more debilitating. I think that's correct.
I think that's definitely right. I think that our experience is that most new spinal cord lesions produce symptoms, not all, but the chances of getting symptoms from a spinal cord lesion are definitely much higher than a brain lesion. It's interesting, Audrey, to hear that at St George's you guys do a spinal MRI routinely. It's certainly at Queen Square we don't. We have to battle a little bit actually for spinal cord MRI. What's the situation in Sheffield, Liz? Do you guys do a spinal cord?
I think it's similar. I don't know. No, I don't think it is routine. As routine as that. No.
So it's interesting. There's this variation across the country.
Yeah, and that's because there isn't comprehensive data guiding exactly justifying whether or not you should do a cord MRI all the time. And even looking at the data out there, in the paper in Magnum's and the paper about spinal cord MRI in MS and NMO, we know that the majority of MS patients have cord lesions. We know that that a good percentage of them can be asymptomatic. It used to be thought that you couldn't have an asymptomatic cord lesion. And the conclusion from the data that we have so far was that there's 25% of patients will have may have an asymptomatic cord lesion, but there are a lot more patients who have asymptomatic brain lesions, which is why we routinely scan the brain. And of the patients that do develop an asymptomatic cord lesion, most of them will have an accompanying new brain lesion. So only about 10% of patients will have a lone asymptomatic cord lesion without a new accompanying brain lesion. So the logic was, or is, that there's a small minority of patients who will have an asymptomatic cord lesion that you will not detect anything on the brain MRI, and therefore is it really worth doing this? And really it's it's looking at the statistics. If you were to be given a 1 in 10 chance of having a devastating condition that we weren't going to screen for, I think that I don't think I'd be particularly happy with those odds. So it's about capacity, it's about being pragmatic. And I think even in Magnum's, who've concluded that they don't recommend that it's optional and that to image the cord in a patient who isn't overtly having cord symptoms, they do say that ideally you would image the cord. And they recommend thinking about imaging the cord in patients who have a cord syndrome, atypical cord symptoms, and who've got worsening of function that cannot be explained by their brain imaging, to make sure that you select those, so you choose those patients.
And I think
so
that for
it's
me,
all about being pragmatic and choosing your patients if you can't do cord imaging in all of them.
from my point of view as a neurologist, one of the situations where I would always image is if a patient's developing progression of sort of walking difficulty, for example, because you might pick up a new cord lesion, but importantly, as Audrey said in her presentation, you can pick up a second comorbidity, and a particularly common one is people having cervical myelopathy from like a disc, and that's so, well, I'm going to say easy to treat, easier than MS to treat because there's an operation for it, but I've seen quite a number of patients who have had a disc compression that mimicked progression.
Yeah.
And of course, picking that up is just so essential, isn't it?
So where are my lesions and how many do I have? I think it's really useful for patients to see their scans, and sometimes they do. I think Wallace, you said before that you tend to show patients scans where you can, so that they can also see exactly where the lesions are and how many there are. And it may help them if they're making a decision about disease modifying therapy. If somebody is a bit risk averse, concerned about medications, hopefully if they sort of see what's going on, they may find the decision a little bit easier to go on something.
I think that's, for me, when I make the diagnosis, I always put the scan up because I think sort of seeing is believing a little bit for patients. Well, I'll never forget once I had a patient who didn't want to go on to treatment. I showed her MRI kind of a year ago, and the most recent one, I said, look, these are new areas of damage that have developed in the last year, and it's really important to be thinking about treatment. And I was sort of talking to her, and her husband was sitting in the chair next to her, and we both sort of missed the fact that he'd fainted looking at the MRI scan. So, maybe I lack sensitivity a little bit being from the Antipodes, but thinking about it sensitively, because sometimes it can be a bit distressing to see the MRI scan. Sometimes patients are quite shocked, I find. They say, gosh, there's an awful lot of lesions there. And I say, oh, that's just average for what we see. I don't count the lesions because I think the actual number doesn't really matter that much. Audrey, you'd be at work for 22 hours a day if you counted every white spot on the MRIs. Would that be right?
I've got quite fast at counting them, Wallace. And I don't count them to give an absolute number, because it's utterly meaningless to give, does it matter if you've got 7 rather than 9, or 24 rather than 32? However, I do like to give a ballpark figure, so I count them really quickly. I may miss 1 or 2 here or there, or overcount, but I think it's relevant if I tell you you've got more than 50 lesions, or approximately 70 or 80 lesions compared to 8. Particularly, but I think talking about the location of the lesions is important, because we know that infratentorial lesions and cord lesions are more highly linked to disability, to increasing disability. So I think it's really important, because that plays into the decision making as well. If you've got somebody who's male, got lots of infratentorial lesions and a lot of cord lesions, I get a little bit angsty. So if I'm reporting in the district hospital that I visit, I put into my report as well, if somebody's got really quite aggressive looking, lots of lesions, lots of poor prognostic factors, then I put in my report to please refer. You may want to consider discussing this patient at the MDT. So I think it's important to have a ballpark figure of lesion number and where they are.
It's really difficult to get that balance of, because you want the patient to have all the information and I suppose put it across so that it's not too worrying for them, but they, you know, they've got all the facts so they can make a decision. And I always think I just wouldn't want anyone to look back and kind of regret something that they've not gone on when it's been offered to them, but it's difficult. It's a really difficult one. So if I haven't had a relapse, then why does my MRI show new lesions? And again, quite a difficult one really. And we know that these kind of patients are a bit more of a concern if they're not on disease modifying therapy. And again, it goes back to the last one really, if they are, so hopefully if they don't particularly have that many clinical symptoms, or especially if they sort of improve really quickly, but then they've got quite a high lesion load, then hopefully it's showing them on the MRI, on the scans, and so they can sort of see what's going on. I think they would probably worry me the most. And in fact, I've had a patient that came over from New Zealand actually, and she in New Zealand it was agreed that she was going on ocrelizumab or ofatumumab, or you know, one of the anti-B cell medications. She had a baby sort of around that time, so it didn't happen. Came back here, and then I spoke to her nearly a couple of months ago, and then she had quite a high lesion load. She didn't have that many clinical symptoms, and funnily enough, I spoke to her today, and she's still not in treatment. And it's just, you sort of think, have a put across the or the information to her, and you know, some people just are like that, and she's a bit overwhelmed about making a decision at the moment. But yeah, it's a bit of a worry, really.
And an even more common question I think we get, Liz, about the MRI is the same, but people feel worse. You must deal with that quite a lot.
Yes, someone asked the exact question on Monday, word for word, really. And again, we know that there's other things potentially going on, whether it's, you know, sort of other MS symptoms that are causing somebody to feel worse, and you know, pseudo relapses, or even just that someone's stressed and overdone it, and they're just having increased symptoms that is causing them to feel worse, but actually nothing's going on at the time. But and I guess progression can come under that, and neuron loss as well, and atrophy, unfortunately. But
and I think as Audrey mentioned, we're just not good at picking that stuff up with the sort of MRI scans that we currently acquire, and hopefully we're going to get better at that in the future. But I guess, you know, we're now in a situation where we have got medications to offer people who are progressing on another DMT, even with a stable MRI. So with the updated NHS England blue tick for siponimod, if someone's had disability progression on a treatment and their MRI is stable, we don't need to wait for new lesions or a relapse to escalate those patients who are slowly progressing. And that sort of feeds into those new ideas we've got about progression independent of relapse activity that we've discussed in these webinars earlier in the year. Now, we're running short on time. We've got quite a few questions, and we were going to discuss a few different challenges. I think that some of this has come up naturally already in the discussion about beyond T2 lesions, what else we could be looking for in the future, and the challenges in spotting new lesions. Audrey showed you a case of someone who had a lot of white matter change, and the GAD was really useful. We've discussed rebaselining. I guess a lot of the questions that have come through have been around capacity, and that's something that's a problem across the NHS at the moment. But capacity is a particular issue for radiologists and neuroradiologists. Audrey, you've got some data to share on that?
Yeah, so the UK has really got quite low in the number of MRI scanners we've got per population. You can see that we're, I don't know about this, 1, 2, 3, 4, 5, 6, seventh lowest in that list of countries, and we're 8.6 MRI scanners per million compared to 38 for the US and 16.3 per million for France. So not only do we have lack of MRI scanning capacity, but we also have a shortage of radiologists. So we were lower than this but for 2021, we were 29% down on consultant radiologists. It's projected, but this is the RCR census of 2021, this is from their report, and these are the headlines, projected to be 39% by 2026. So the number of consultant radiologists is not going up as quickly as the demand for MRI is. So yeah, so we've done our best to try and tailor. For MR capacity, we do the minimum. So for follow-up, we really do very quick, slick scans so that they're short examinations. I know we do the cord, but we really only do 3D flare, DWI, and a cord. So they're quick scans. We try and minimize MRI time, but these are real physical challenges that we face.
There's some questions around capacity, Audrey. One of them is around the issues that there's not many hospital car parks in the UK without an in-health MRI scanner sitting in the car park. But often there's some questions about whether the quality of the scans are good, and then the quality of the reporting. We all have our favourite neuroradiologists, so we always go and bring a coffee and some difficult cases to discuss with them. But often the neuro stuff is being reported by, when you Google the person, they're a musculoskeletal radiologist reporting in their spare time. Fair enough, but it's not the quality we're used to. And so the question is, outsourcing, is it a blessing or a curse? Or
probably a bit of both. It's never black or white. It's outsourcing has solved an awful lot of our urgent capacity issues, both the scanning and the reporting. It has saved us in times of need, but as you allude to, it's very difficult when you don't know the radiologist. If you sometimes, I must say, I've seen some of the outsourced reports that we've got back have been from neuroradiologists, and some really very experienced neuroradiologists. So I don't know that we always have a problem with the quality of outsourced reports, and I accept that it's probably quite variable. But what's definite is that MRI vans are prone to a little bit more artifact. They suffer from artifact that in a van that you wouldn't get in a static building, just because of the structure that the scanner is in. They're a little bit more vulnerable to the environment. So no, it's not great. We also have a lot of our MS patients scanned on a van, just because the amount of imaging has gone up so much, and there are problems that with some, particularly with the cord imaging, actually, can be really artifacty and very difficult. But also access to climbing up the steps of I've had complaints about MS patients finding it actually quite difficult to get in and out of a van, going up and down the steps can be quite tricky. So it's not ideal. And actually there was some data that I saw on that same census report that showed that the amount we spent on outsourcing equated to some phenomenal number of full-time equivalent consultant radiologist pay. So we pay over the odds for this. But it's about getting the money to the right place at the right time to build new MRI scanners, because that's not easy either. So actually, even though it's costing so much, it's still possibly the quickest, most expedient solution for the time being. So we do need a lot more static scanners.
There's a question, well, there's quite a few questions for you, Audrey. I think we need to have you back for another webinar next year, because MRI seems to be a popular topic. But there's also a question around you've presented about the 3D flare, which we use, and it's changed our life in the last 5 years since we've been using 3D flare. Absolutely huge fan of that from a neurologist perspective. People are asking, who should I speak to at my hospital to start using 3D flare? I work at a district general hospital. and we still just get standard T2 scans.
Yeah, it's tricky, it's slow. If you could speak to the superintendent. I tried this last week. At the hospital that I visit, I emailed the superintendent and said, you know, there is no need to do, you've done a 3D flare, there is no need to do a 2D as well. And got a bit of kickback going, our radiologists are not happy, blah, blah, blah. You could refer them to the guidelines. The UK guidelines, sadly, are not published yet, but we hope that it'll be imminent. But you can use the magnums, because that's a consensus statement, and that really covers most of the world. So that's a really powerful document, and in there that really spells out all the evidence for why 3D flare, you know, getting a good quality 3D flare is really important. Now, that said, they also do say if you can't get a good quality 3D flare, say the scanner is old, the radiographers aren't familiar with it and get it all wrong, you're better off with good quality 2 planes of 2D flare rather than a really awful 3D flare. So the 3D flare's got to be good quality. So if they can't do it where you're working, then there's going to be you know, there'll be a period of time where we're trying to educate everybody and trying to spread the word, so that it takes time for people to catch up.
And there's a last comment on what are we going to do with all these people who are stable on treatment from beta for 3, 4, 5 years or even longer. We've got so many stable patients now on treatment. Thankfully, we keep getting these reports back saying no new lesions, which is wonderful and good news for our patients. But reducing the number of scans we do. I know Audrey spoke about the guidelines, maybe drop to every 2nd year. The BSNR are suggesting, I think in the future actually we'll be using neurofilament to guide when to do MRI scans. So if someone has been stable for a couple of years, let's just whack on the serum neurofilament to their monitoring bloods every 6 months. And if the neurofilament's fine, they feel fine, we'll hold off on an MRI scan till the neurofilament's rising. That's, you know, that may be the future. We need data to support that. Now we are out of time. So I'm going to say thank you to Audrey and Liz. I think it's been a really interesting discussion. We've had a high number of people join the first part of the webinar today, and we've had lots of questions. So I think MRI is a hot topic and maybe something we need to continue discussions on again next year. So thank you very much for joining us, Liz and Audrey. That's been a really interesting discussion.
Thank you.
Thank you so much.
Thank you.
Now, just as a plug before we go to a really quick short break, the applications are open for next year's masterclasses. The foundation masterclass is over 50% subscribed already for 2023, but if you've got more junior colleagues at your centre, or you've not been through the MS Academy, we're a friendly bunch, please come and join one of the masterclasses next year.